Welcome back to part 2 of the SIBO Doctor podcast, and let's jump right back into it. So what's the difference? I've actually been meaning to look this up myself, so I'm glad you're here. I can ask you directly because, here in the Northern Rivers and you on the Sunshine Coast, we get a lot of rainfall. And then it's a muggy summer day. You open your closet and you have a leather jacket and it's just completely covered in mildew, right? Is there a difference between the toxic black molds like Stachybotrys and all that, and the just simple sort of moldy leather shoes or jackets?
Yeah, there is. There's a difference. So and Dr. Shoemaker kind of did some classification on different species of mold, and that's also one way you can interpret the ERMI testing is looking at what species of mold are present and getting an idea of what level of water contamination might be present. So, for instance, if you've got a moldy leather jacket, although Fonzie would be horrified, you're not going to be you wouldn't have Stachybotrys in that most likely, because it's not a very, very high level of water, let's say just moisture levels that's led to that. It's not of the same level as a leak. And therefore it's most likely going to be related to Aspergillus penicilloides and Aspergillus versicolor and those sorts of species. So Dr. Shoemaker referred to those as low water content species. And then he referred to Wallemia, which is it's a very common one that shows up on ERMI tests as being medium water concentration. And then the top ones were the Stachybotrys and Chematomium, and Stachybotrys is what often is seen as toxic black mold. But one kind of myth is that it's only the black mold that's toxic. That's actually not true. But certainly black mold, if it's Stachybotrys, is a problem. But there's all different types of mold species that can be a problem. So yeah, I think that's a really good question, that if you've just got surface mold on your possessions or on your clothing, that's going to be different species to what's actually going to grow in building materials in a wall that have actually had water run right into them. And and there's a different profile, and you can work with a mold professional or a mold inspector once you've had an ERMI done to really look more carefully at those mold species that have showed up and what they indicate in terms of the underlying problem in a home.
That's really good information. So let's imagine we have a patient listening or a person listening that's been diagnosed with SIBO, has been treated for SIBO, and then cleared SIBO, but the symptoms remain and they are resonating with what we're talking about here. They've done their maybe ERMI plates, or they've done their visual test, they fail it. What's the next step that these people should look into?
So look, there's not just one way of doing this. I'll make it clear, but it does depend on the patient's circumstances. But we talked about the mold sabbatical. That's definitely something to consider as a first step. Now, the next thing and the next step in the Shoemaker protocol was using binding medications or supplements. And the main one that was used is called cholestyramine. And, those who are in the medical world will know that was used as a cholesterol-lowering medication, and that it's what's known as a bile acid sequestering agent. What does that mean? Well, that means that it actually binds onto the bile acids and pulls some substances, including cholesterol, out of the bile. And it seems that one of the substances it binds is actually mold toxins. And I do think it does seem to be a big key in SIBO patients, because getting and binding onto the bile and taking the mycotoxins out of it does appear to then have an effect on improving the quality of the bile. And that may be for some patients an important outcome, is getting the quality of the bile improved, and that we know the quality of the bile that you're secreting does have a really important effect on the microbiome, and so that's probably the next most important thing to look at. It doesn't have to be something. Not all patients tolerate cholestyramine. The other medication that's been used is called Colesevelam, or Welchol it was marketed as in the United States. And then, and often I will recommend more the pharmaceutical binders if someone is still being exposed to a water damage building, because it's like, it's like you've got a leaking boat and you're trying to throw the water out. It's kind of a pretty difficult battle because your boat's still leaking. So you want a pretty strong bucket to be throwing that water out while your boat's still leaking. And it does seem that cholestyramine and cholevesylam are stronger than the natural binders in terms of binding mycotoxins. But having said that, there are a number of natural binders which do appear to have some effect on binding mycotoxins. And that includes charcoal and chitosan and zeolite and bentonite clay, I guess, are the main ones. And
acacia gum? No?
Acacia gum may have some effects. I haven't researched that specifically. There's some other ones which have been looked at, but they would be the main. They would be the main ones. And there is some new testing, such as the Great Plains urine mycotoxin test, and some physicians, such as Neil Nathan, are saying, well, maybe you should base your binder selection on what's showing up on the urine mycotoxin test, rather. But at this stage, I'm still personally of the belief that just using, cholestyramine or cholesevelam is the best idea if someone is still getting significantly exposed to a water damage building.
I would totally see how that's going to work for somebody who's diarrhea dominant and has very classic SIBO symptoms. And it's interesting because in many of those cases, bile acids are actually being damaged by bacterial gases and fermentation. And that's one of the reasons why some people resort to using ox bile and using, bile movers and cholagogues and choleretics and all of that. And so in my experience, using cholestyramine has been more on the constipation side, that it's definitely more of a constipating substance. Have you noticed a worsening of that when you prescribe it to constipated patients? Or would you maybe use something else in those cases?
Actually, it's quite variable. I remember there was one case of a child, I think she was 12 years old, and she was very, very constipated and clearly had a very severe mold toxicity problem. And I was actually quite reluctant to give her the cholestyramine, but I decided to give it a trial, and she said that her constipation actually went away. And
Interesting.
so there is definitely some unanswered questions. It's a very fascinating area, but it does seem that some of the mycotoxins themselves may be causing constipation. So there's definitely a lot of unanswered questions. And I do think that, use of bile acids could still be very useful for a patient with mold toxicity because, you may be removing bile acids at the same time as removing mycotoxins. So, taking bile acid factors with each meal, along with possibly HCl and or digestive enzymes, could be a very useful addition to the treatment for this condition.
So excellent. Wow, we're getting a lot of questions answered. Now, let's go back to the motility aspect and VIP, as you mentioned, vasoactive intestinal polypeptide. That can also be prescribed, right? You can, when you test for it, you test for VIP, it's a blood marker, and if it's low, do you just sort of give everyone with mold toxicity VIP, or do you only when they test low? And have you noticed any improvement subsequent to supplementing with it or prescribing it in terms of motility? Which is a hard thing to ask because, as we know, the motility in the upper gut is not necessarily related to peristalsis in the lower gut.
Right, yeah. Great question. And you like easy questions, right? So first thing about VIP, firstly, it's a very fascinating substance. And one of the big things about it is that it's probably only low in about 1/3 of patients and probably normal in about 1/3. And actually 1/3 of CRS patients are high in it. And that seems to just be a compensation. And so if you're looking for this condition and you see someone with a high level, don't let that put you off. And we're basically saying that the normal reference range is around 8 to 20 nanomoles per litre if you're having it done through the local laboratories, not the 0 to 50 nanomoles per litre, which makes no sense whatsoever. And so if you've got someone with a low level, then you could say, yeah, they probably have the strongest indication for it, but it can also be given for someone with a normal level or even high, because what Dr. Shoemaker found is often these patients will be intracellularly depleted in VIP. So it's not just the low, the patients who are testing low, But the thing about it is it's kind of the cherry on top of the Shoemaker treatment protocol in that it's often given last. And there are a number of different criteria for its use, including that the visual contrast test has returned to normal, that there's an ERMI score of less than 2, he was saying, or for severe patients, less than -1, which is actually quite hard to achieve. And that one needs to be free of the nasal staph called Marcons, which is another part of the treatment. And have a normal lipase level is the other thing, because there is a small risk of pancreatitis with it. So often it's about a year down the track on the treatment, and after people have got into a safe residence and have taken cholestyramine or whichever other binding agent they've used, often they will have already done some nasal spray treatment for Marcons, etc. And sometimes going and looking for stealth infections such as tick-borne infections will have already been done. And then we're sort of at the stage where we're ready to introduce VIP nasal spray. And it's quite fascinating what happens. VIP, if you look up the physiological effects, it's a big dilator of smooth muscle, including in the gallbladder and liver. So I've had one patient has started passing massive amounts of parasites as soon as I gave VIP. And another one had massive amounts of Candida albicans coming out when she had. So it really gets things moving. And I actually think the first thing is that it helps the liver and gallbladder before helping the bowel. But clearly it has very, very strong effects. And I do recommend people have done some cleansing of their liver and gallbladder area before going on it, such as liver gallbladder flushes and so on. Otherwise, I believe that the risk of pancreatitis, which is 1%, is due to the fact that people have a clogged up liver and gallbladder full of sludge, and then you give them something to dilate that, you may just get a lot of inflammation. So that's one recommendation, is that they do some cleansing, and then it's often started at 50 micrograms 4 times a day. But for sensitive patients, you can start at 1/10 of that dose. And and for patients who have significant amounts of atrophy on their neuroquant scan, which is a form of volumetric analysis of brain MRI scanning, it may be increased all the way up to 200 micrograms 4 times a day, as per Dr. Shoemaker's research. And I definitely think it does have very strong effects in the intestines, and often patients do report that their bowels do eventually start working better and so on. So initially I thought that VIP was the sole answer of why patients were getting SIBO with CRS, but now I think it's just one of the factors. And I do think that would also assist them in being much less likely, rather, to get SIBO again in future, but also addressing the immunogenic factors and the bile, I think, are also very important.
So, and what do you do for improving bile flow in those patients then, other than VIP? Do you do things like taurine or?
I haven't been doing that as a general kind of like as a routine, but certainly if they had testing done that suggested that they were deficient, they could be looked at. I do believe coffee enemas are very, very helpful, and I do recommend them. And because the thing about using binder medications and so on is it assumes that you've got enough bile coming out to bind onto, because and so some patients are just not excreting enough bile. So if you do a coffee enema, and this has been shown endoscopically, it will significantly increase the amount of bile being secreted. And therefore, the ideal thing is that you take a binder like cholestyramine and then do a coffee enema, and then you can be sure that there's going to be quite a lot of bile for the cholestyramine to actually bind onto. And I do believe that they gradually improve the quality of the bile through getting rid of, some of the sludge and, just all this different poor quality fats and so on that sit around in the gallbladder, from people who haven't been, if people haven't been eating a healthy diet for their whole life. And slowly through doing that kind of cleansing, it will slowly improve. But yeah, sure, you can, taurine, that can be used as well. I'm not saying there's not other ways that can be utilized as well in addition.
Well, I'm a big fan of coffee enemas. There is always a word of caution that, you kind of look into it before you do it. How much coffee do you put in your coffee enemas?
Just 1 teaspoon or something like that. It doesn't need to be a huge amount, really.
Yeah. Good.
Yeah. And, obviously one needs to make sure the temperature is right. We don't want anyone burning themselves.
Yes, and usually I put it into the enema bag.
Right.
So so that there's more volume than just 1 teaspoon. And one thing I would say, I think you brought up a really good point about that very often, and this is, in this new patient course that I have created called the SIBO Success Plan, I talk about this full bucket concept, which is patients that come to see us are not just, plagued by one problem very often. And especially specialists like us, you being the mold specialist, me being the SIBO specialist, we see people that have failed treatment over and over, and they are referred to us. And so we have to sort of investigate these different layers of what is all contributing. And you mentioned a really congested liver and a lifetime of other poor eating choices, perhaps. And that's really important as a concept, that because when you go onto the Facebook forums, my SIBO is not clearing up, I keep relapsing. I teach people about this concept of how full is your bucket? How much burden does not just your liver have, but also your overall constitution in terms of, do you have a heavy metal toxicity? Do you have chemical overload? Do you, and that can all be investigated with different, not just tests, but even just questionnaires where people just select what they might be having. Root canals, as I mentioned earlier, is really another big deal for a lot of people. So I'm just wanting to mention that because a lot of people are following other people's recommendations that they posted. I cleared my SIBO using X, Y, and Z. Well, that doesn't apply to you because you have other issues going on that person may not have had. So that is, I think, one of the reasons why SIBO has turned into this sort of chronic illness that is really central to a lot of other conditions that have totally different onsets. So just wanted to sort of have a little conversation about that, because we are seeing people that are very, very ill and they do need multiple approaches and detoxification and different staging of treatment.
Yeah, I think that's a really good point that you've brought up, Nirala, and we have to be holistic. And, sometimes getting stuck on one disease label can really act as a real block for people. And although, it's very, very helpful to identify if you've got SIBO or if you've got SIRS, we really need to take a whole person approach to what's going on. And, Dr. Jill Carnahan, who's a functional medicine doctor in Colorado and part of the new ICI group that I'm a part of, she talks about the concept of total toxin load. And, that's clearly not just mold that we're talking about and mycotoxins. We're talking about heavy metals, we're talking about chemicals, we're talking about stealth infections in there as well. And really, when she looks at mast cell activation syndrome, and those who are interested in this can look up a webinar that I did with her around 2 years ago, which is on YouTube. She looks at the total toxin load as being the primary driver. And yes, probably mold toxicity is most likely the primary driver, but all these other toxin contributors are going to also be there, and they also need to be addressed. And so therefore having an overall detoxification regime as really central part of your lifestyle, I think is very, very key.
That reminds me of over 20 years ago when I first started this journey and became a naturopathic doctor and practiced in Montana. And when what was now known as mast cell activation syndrome, or back then it was just histamine intolerance or people having hives. And my mentor, I was a resident with Dr. Margaret Beeson, and she was like, just work on the liver. And it worked every time at that point. People with hives, because the liver can't clear histamine. Now I wish, I'm seeing people that are way more complicated, but it's just a really nice reminder that a lot of things can work. And just listen to the podcast I did with Dr. Christopher Shade, where we really go into the emunctories a lot more. This is a good, I think, place to close. But before I close, I wanted to give you an opportunity to, tell us where you are. This is also going to be available in the show notes, all of your website links. And you mentioned you have a program that people can purchase to find out more about mold.
Yeah, thanks, Nirala. Yeah, so I created a course around 2.5 years ago when I saw how overwhelmed patients often are when they're diagnosed with SIRS and mold toxicity. And, I think really one big part of it, which is underestimated, is that, the panic and the anxiety that happens can also have a detrimental effect on the healing process because, and the limbic system of the brain is also very, very key in either promoting inflammation or healing from inflammation. So the purpose of the course was really to help people reduce overwhelm and feel a lot more clarity around their illness and really feel like they had a roadmap for being able to know where they were going with their treatment and to feel in control to a certain degree of what was going to be happening as part of their treatment process. And I found that a lot of the information that was already out there on the internet and Facebook and so on was quite confusing. And therefore, I created Mold Illness Made Simple. It's an 8-week online course. You can join it at any point. There's not like specific joining dates or anything like that. You can just join whenever you like and basically download the PowerPoint files and the videos and the PDFs and so on, and really just go through a very, very structured approach to understanding mold toxicity. And, it just starts off understanding going through the idea of, could I be living in a water damaged building? And then the next part of that is, could I have CIRS? Then how do I test myself? How do I test my building? And then what are the different steps of the treatment protocol? So it's very structured and it's very simple. And so we really make a point of just dealing with one bit of information at a time, because looking at people's brain scans with mold toxicity, we know that, they may not have the capacity to take in really difficult multi-layered concepts. And so far the feedback has been really good. People say that it definitely has helped them to feel less overwhelmed and more clear. And so the website is www.moldillnessmadesimple.com. And
that's MOULD
no,
or
just
MOLD?
MOLD, the American way.
Okay.
So we really
Mold
created it for
Illness
the American
Made
market.
Simple.
Yeah, that's it.
.com. Great, thanks very much. And your clinic?
Yeah, clinic.
Are you still seeing new patients, or you've?
My colleague, Dr Rashmi Kabina, is seeing new patients, and she's very, very skilled with mold toxicity and mast cell activation syndrome and a range of other associated conditions. So our website is lotusholisticmedicine.com.au, and that's holistic just spelt with a H, and the number is 0753133577 for those that are in Australia.
Thanks so much, Sandeep. This has been so illuminating. I really appreciate your expertise. And I'm sure we'll have many more conversations in the future. We run into each other at different conferences. And as this field evolves, I'm sure you'll have a lot more to share with us at some point.
Yeah, thanks. And I've enjoyed the chat, Nirala. And I really hope we can work together further and really try and crack some of these complex areas.
Mm-hmm. That need to be cracked.
That's right.
Thanks a lot, Sandeep.
Welcome.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.